Welcome, everyone. My name is Todd Thompson, and I am a nurse at the Tucson Veterans Hospital. A little bit of background is that the Veterans Hospital is actually the largest integrated healthcare delivery system in the United States. We have over 228,000 employees and care for almost 8 million veterans. An interesting point is that the VA is part of the beverage model of healthcare delivery, which is universal healthcare by a central government financed through taxes. So the VA is a single payer healthcare system that you hear so much about in the debate about healthcare. The part that we are going to talk to about today, though, is the patient-centered medical home model as used at the Tucson Veterans Hospital. I'm sure you're all aware that the patient-centered medical home is a primary care practice that coordinates care across all medical centers and is very interdisciplinary and designed to reduce specialist and emergency room visits, as well as focus on preventive care and care management. The VA's version of that is called a patient-aligned care team, which is essentially a patient-centered medical home model, very focused on the partnership between veterans and the healthcare team, very accessible to clients. You have scheduled as well as walk-ins, and you can meet with the primary care provider or other professionals within the care team, and has a very good telephone and electronic portals. It's also very coordinated. It works on all aspects of the veteran's health and very team-based. The one that we are going to be talking about today is the agve primary care clinic, which is a medical primary care clinic that focuses on treating veterans that have a mental illness. It is actually co-located within the mental health clinic, so it is accessible to all the psychiatrists and mental health staff. And it treats 1,485 veterans who have a mental illness, and it treats them medically, not psychiatrically. Anytime that we're going to start talking about a microsystem model of care, I think it's important to talk about the microsystem, which is the leadership above the agve clinic. Our agve supervisor is part of their own microsystem of the supervisors at the hospital, all the way from the hospital director down to the agve clinic supervisor. And they are a study in complexity. They are constantly working with competing goals and limited resources and different viewpoints. A good example of this is the scandal up at the Phoenix VA, where they had falsified wait times. And the core problem there was that they were using performance-based bonuses. And when the leaders couldn't meet them through their resources, they found ways to cheat. So it's interesting to look at kind of the unexpected outcomes of doing things like performance-based bonuses. Are you rewarding good behavior, or are you encouraging bad behavior? Our organization and culture and support, however, at the Tucson VA and at the agve clinic is very good. We really work to fulfill President Lincoln's promise to care for him who has borne the battle. And it actually percolates throughout the VA and is very important. I do think the agve clinic has an interesting kind of organizational culture and support because it's supervised by mental health professionals. So you have primary care doctors and primary care staff that is under the mental health side of the house. And so it does have a strong mental health focus and has a good, strong relationship with working with the psychiatrist and psychiatric medications. But it sometimes loses a little bit of focus on other chronic medical conditions, and it's kind of separated from the normal hospital medical system. So it sometimes has a little coordination problems along that. Like I said, that the Agave Clinic is a medical and mental health integration team. It has a strong commitment to their population, a very good example of patient-centered care, and has a excellent history of working with difficult clients. I do think that, having that mental health focus, however, can change the staff perception and can also create a feeling in the rest of the hospital that it's their problem instead of it being the entire hospital's problem. The characteristics of the clinic is that it's split up into two teams. Each team has a primary care doctor, a registered nurse, an LPN, and a social worker that all work together to provide care to 750 veterans. So the whole clinic has about 1,500. The primary care doctor does the doc stuff. The RN does care coordination and helps the doctor. The LPN focuses on vital signs, clinical reminders, intake kind of stuff, and we're getting the doctor moving. And then we have a social worker that also does care coordination, referrals, advanced directives, things like that. The two teams are supported by the clinical support team, which is the supervisor, a pharmacist, two unit clerks, and then a triage float nurse that's able to move around as needed. We also have a very strong information and healthcare technology. We utilize CPRS, which is one of the oldest computerized patient record systems in the United States. It enters, reviews, and continually updates all information about the patient. It is very comprehensive. It works on inpatient, outpatient, pharmacy, prosthetics, anywhere that the patient goes, it's recorded in CPRS. It has a very good clinical reminder system to keep track of preventive care. And you can also pull a lot of data out of it if you know how. And you'll see a little bit of that coming up. And then the patient has a healthy vet portal through the internet that they can make and check appointments, refill prescriptions, secure messaging, and even as a smartphone application. Unfortunately, however, a lot of patients don't use that because we do have a little bit of an aging population, and I would like to see them utilize that a little bit more. So, in the Agave Clinic, we have found that one of the problems that we have been dealing with is the staff feels like they're spending too much time dealing with walk-ins. Um, Actually, it has been up to like 25 or 30% of the total time in a day is focusing on walk-ins, which when you have a full schedule booked up can be a lot of time. Um, what we were able to do is to get into CPRS and pull up the data of how people are coming in and what they're coming in for. And what we found is that about 10% of the total panel at the Agave Clinic makes up about 65% of all the walk-in visits. So when you look at it, what we're dealing with is what you would call the frequent flyers, or people who have a interdependence with doing walk-ins. And it actually works out to about 75 patients per the two teams at the Agave Clinic. The most common chief complaints is management of chronic medical conditions. My blood pressure's out the roof. I can't breathe. My blood sugars are out of whack. Of course, pain is always a major issue. People come in because they can't figure out how to utilize refills, or they ran out of medicine. And instead of calling, sometimes they'll come into us because we can be so um, accessible. Injuries, and then people who need help that ends up being referrals or consults out. Out of all the walk-ins, actually most of them go home. 70% of them go home immediately. 18% are referred out to another area of the hospital and go home. And only about 12% end up going to the emergency room. And of that 12%, most of them end up going home. When you look at the workflow at the Agave Clinic, you'll see that a patient will either come in for an appointment or as a walk-in. they have to start at the unit clerk, who then will kind of juggle those appointments. And the unit clerk will either send them to the triage nurse if they're a walk in, or they'll go to the LPN where they'll get vital signs, do some clinical reminders, some data collection before they see the primary care doctor. Like I said, the LPN works to kind of drive the care of the primary care doctor and keep them on track. On the other hand, if they go to the triage nurse as a walk-in, the triage nurse will do a little bit more of a comprehensive assessment and may tell them at that point just to go to the emergency room, or will consent, will talk to the primary care doctor to come up with a plan. And it could be that they're going to have to see the doc, or sometimes they might go and see a nurse or a social worker or a pharmacist to kind of work out their problem. So the triage nurse is able to kind of farm that out, but they're required to staff it with the primary care doctor. And that can add a lot to the primary care doctor's time when they're trying to see regular patients, as well as consult with the triage nurse about dispositions. After someone sees the primary care doctor for a regular appointment, they will often talk to the nurse, who will do further education, talk to the social worker on referrals or resources, or go see the pharmacist, who may educate them about the medications they were just prescribed and different things like that. So the plan that I am proposing to kind of deal with this is to shift the walk-ins to telehealth or nurse or social work visits. So instead of being reactive, where we are waiting for these frequent flyers to come in and kind of working on clogging up the system, what we're going to do is we're going to proactively reach out to them through telemedicine, phone calls on a regular basis, and preempt some of these walk-ins. So what we're going to do is review the cases and see if we can kind of figure out who the best person to deal with them are based on the level of care. So people who are dealing with diabetes, COPD, upcoming care coordination things that are medically based, they might be put on the phone list for an RN to call. People who need a little education about checking their blood pressure at home, smoking, weight, clinical reminders, different things like that. Or maybe they just kind of need to talk to someone. The LPN might end up calling them. The social worker will be a little bit more when it comes to dealing with people that have a history of missing appointments, or maybe we think they're just coming in because they're lonely and they need someone to talk to, or they need a little bit more reminders. And then also the pharmacist may make a few calls to people who frequently have medication issues, but they will probably have a little less need because they're pretty busy, but might be kind of the second line call if we've identified a medication issues with some of the other people. So essentially, under the medical patient care model, you can kind of work towards being proactive with your population and say, this is a problem that we are having, and let's look at the data and let's look at who can kind of work on this. And instead of being reactive, as we can often be, dealing with whatever comes in the door, we can be proactive and see if we can get on top of this issue. This is something that I'm hoping that we'll have very good success with, and the staff is actually excited about it. So here are my references. I hope that you look at them and get a good idea of what we're happening, and I'm hoping that at some point I can kind of let you know how successful this has been. I really appreciate talking to you, and I look forward to working with you all in the future.